Hi, friends. Good afternoon. I'm sure that now all of you are back to work again, the busy days in between the lock in and lockdowns and lockouts. So I take great pleasure in welcoming you all to today's webinar. This is our Obstetrics Society of Hyderabad OGHS webinar, which is being actually we have the educational partners, the Bharat Serum and Vaccines, Bridging Bharat. And of course, we have our academic partner, the TOG, the team TOG, who is always very proactive. And I think they have become very close and dear to the hearts of all the Foxians when they're able to reach out to all of us in this period of lockdown. So, friends, today the webinar is a different kind of webinar. Why do you think so? We have with us a variety of speakers. We have with us our own Dr. Jaideep Tank, the Secretary General of Foxy, and who is actually worn many hats and one of the finest speakers of our Foxy, who is going to actually talk to us about what we need to know about abortion in India, the law and practice. We have so many dilemmas, questions. We really wonder, what is right, what is not right. Suddenly somebody calls up and says, now I have this patient, the patient is so many weeks. Now there's nobody to being with the patient. Can I do it this place? Can I do an MTP in the clinic? Or do I need to wait? And especially so now in the COVID period. So to clear all these dilemmas, we have Jaideep with us. And welcome, Jaideep, for being with our OGHS Hyderabad. So warm welcome to Jaideep. And we have another special guest, Dr. Rajalakshmi. Now, Dr. Rajalakshmi is the professor of Usmania Medical College. She's heading the three biggest hospitals, the public sector hospitals of Hyderabad. The Gynaecological, which is now the Petla Burj, which was one of the oldest institutions from which even my mother passed out and my uncle, Professor Rajaram. And GMH is like, it's one of the pioneer institutes in our state, right from Andhra Pradesh to now Telangana. If there is a state of art institute, that's the GMH. And she's heading the SBH and even the Nilofer hospitals. So welcome, Dr. Rajalakshmi. And she is going to share with us how Telangana is coping up with the COVID situation, how the public sector is actually pitching in and doing the best in the obstetric care in the COVID times. So we are very happy to have with us Dr. Rajalakshmi, who is going to talk on that. And then we have the other speaker, none other than our own Kiranmai. Kiranmai is known to all of you. We know her passion for working for the Foxy, be it right from the programs, from the AICOGs to all the conferences. And she's always there. And her passion is also about all the laws, the MTP, be it the MTP law, be it the maternal mortality, or all the issues which actually affect the public health. So welcome, Kiranmai, to this session. So friends, we are going to have a fantastic session of all the three speakers. And Kiranmai is going to talk to us about RH ISO immunization. And she's going to tell us how we can give the best possible care in this RH ISO immunization. So friends, I take the opportunity to welcome our Hyderabad Society President, none other than Dr. Vindhya, my dear friend, Dr. Vindhya, who is the Hyderabad Society President. And we have, along with Vindhya, we have Archana. Archana, welcome. She's the secretary of the Hyderabad Society. She's become the secretary in the COVID time. So she's being able to run the show thanks to the online platforms and everything. And welcome, Archana, to this webinar. And I shall now give the mic to Dr. Vindhya to please conduct the proceedings.
Welcome, Dr. Jaideep. And it's a real job to introduce Jaideep, and I was just telling him. You all know him as Secretary General of Foxy for a long time. He was the past president of Mumbai Society and the chairperson of Committee for Safe Abortion. And he was the deputy secretary ever formed and ex-chairperson for publication and newsletter of ever formed. And he was the chairperson of Foxy MTP committee in 2004. And he consults in Ashwini Hospital, Mumbai, and co-founder of Esperanza Healthcare in Mumbai. And he's an IVF consult, and he consults in 15 centers in Mumbai. And he manages about 3,500 IVF cycles annually. And he's the main person in the amendments of the MTP Act in October. And he was the main negotiator with the government of India. And he's working on various projects with FIGO and Everford. And the main thing right now, what he's doing for MOGS is he's doing a program or a project assisting the underprivileged women for menstrual hygiene. And he's the person who started the Foxy e-voting. And we have Shanta with us now because of the e-voting, or we all voted for her virtually. And we are looking forward for his talk on abortion in India and the law and practice. Welcome, Jai.
Vindhya, before Jaideep talks, I have to tell all the viewers, like MTP, if anyone has any doubt, you should actually listen to Jaideep Tang. And that MTP is something very close to his heart. He's very passionate about it right from the time he was a chairperson of the MTP committee. And from those days, I've been seeing him. And now in his present position in FIGO, when he's closely, working with women's health. So, and he makes it very simple for all of us to understand. So I'm sure that Jaideep will be able to guide our Kiranmai also to go forward in this MTP line. Thank you, Jaideep.
Thank you. Thank you very much, Shanta. It's such a pleasure to speak to the ONG Society of Hyderabad. Always a pleasure to come to Hyderabad. I hope that very shortly Hyderabad will host yet another of their famous and popular conferences, and I will be able to come to Hyderabad and meet all of you in person. And of course, thank you very much to the dynamic President-elect of Foxy, Dr. Shanta Kumari, for roping me in for this webinar. Thank you so much, Shanta, not only for this webinar, but for all your support over the years and, of course, your very kind words just now. Thank you also, of course, to Dr. Vidya, Dr. Archana Singh, the President and Secretary of the Hyderabad Society, and the entire Hyderabad Society team. I must apologize in advance to the speakers who are going to follow me. I would have really liked to stay and listen to your presentations. Unfortunately, I'm waiting on a primie who is around 5 centimeters now, and I will probably have to leave, once she's around 9 centimeters or so. So I hope you will excuse me when I finish my talk, answer the questions, and then may have to leave to go and deliver that patient. Let me start my presentation on abortion in India, law and practice, by first congratulating everybody who delivers babies in India. Sometimes I feel that we don't appreciate ourselves enough. As of now, India has the lowest ever maternal mortality in its recorded history. What does that mean? It means that every day, 30 more pregnant women are now being saved in our country in 2016 as compared to 2013. And this graph is only moving upwards. So if you are sitting at home, can I ask you all to just please put your hands together for yourself? Because it is us as the obstetricians and gynecologists of this country, as the primary healthcare givers for women, who are responsible for this all-time low maternal mortality. Having said something so upbeat and nice, I hesitate to go on to the next slide. But go on I must, because every life is important and every life is precious. I'm going to start this presentation with this story. This is a story about a 12-year-old girl who was living in a tiny remote village in one of the big states of our country. This was a 12-year-old girl whose parents were daily wage earners. They used to go every day in the fields to earn their living, leaving this girl with the uncle, whom they thought is a trusted relative. The trusted relative, unfortunately, turned out to be a pedophile. Imagine the plight of this poor girl. Her parents are going out every day, leaving her in the hands of this so-called trusted relative, and this trusted relative rapes her repeatedly until the inevitable happens. She gets pregnant. But she's only 12 years old. She's not very educated, neither are her parents. And due to all sorts of family pressures, peer pressures, she doesn't even realize that she's pregnant till she's almost 20 weeks pregnant. By the time she musters up the courage and her mother realizes that she has not got her periods since 2 or 3 or 4 months, and the mother takes her to the primary health center for an examination, she's already 24 weeks pregnant. She gets referred to her obstetrician, but at 24 weeks, as I will tell you later, abortion is not permitted in our country. Add to it the conflation produced by the POXO Act because she is 12 years old. And you have a situation where this poor family, instead of going and earning their daily living, has to start taking the rounds of the courts and the medical colleges and the medical boards and so on and so forth. By the time they approach the Supreme Court, unfortunately, she's already 32 weeks pregnant. So not surprisingly, at that time, the Supreme Court says that now you are 32 weeks pregnant and we are sorry, but we cannot give you permission to have an abortion. So this poor 12-year-old girl, I mean, just imagine her plight. She's been abused repeatedly. She's been raped repeatedly. She's pregnant and now she has to carry a pregnancy to term and deliver a child. Imagine the effect this has on the fabric of that family. This is not a new story. Worldwide, it's estimated that 44% of all pregnancies are unintended. Of course, all the unintended pregnancies don't result in abortions, but from the ones which result in abortion, that accounts for 55.7 million abortions every year, of which at least 50% are to a certain degree unsafe. How many abortions in India every year? This is a study from the Guttmacher Foundation, which was published in the Lancet, and they estimated 48.1 million pregnancies and said that abortions accounted for 1/3 of all pregnancies. And they said that in India, almost 50% of all pregnancies are actually unintended. So this study estimated that India has 15.6 million abortions every year. 15.6 million. Just let that figure sink in. Surprisingly enough, what they found was that only 3.4 million abortions, that's 22% of all abortions, were actually obtained in health facilities. All the other abortions were obtained outside health facilities. From all the abortions which took place, 73% were medication abortions. This drives home the point that medication abortion has quickly taken over, and patients and doctors have adapted to medication abortion as the primary method of providing abortions in our country. I know the WHO is not necessarily very popular nowadays, but what they said about abortions was at least correct. And they said that almost all abortion-related deaths are preventable. When abortion is performed by qualified people using correct techniques and sanitary conditions, it is said to be one of the safest medical procedures. For me, this makes it even more ironic that 4 women die every hour from unsafe abortion in the country, and in India, 1 woman dies from unsafe abortion every 3 hours. Imagine that a procedure which we give to our junior most residents, and women are unable to access this procedure and are dying for want of this procedure. Having established the quantum of the problem and the fact that the large majority of mothers who die because of unsafe abortion can actually be saved, let me move on to the MTP Act of India. And whenever I talk about acts, legal procedures, so on and so forth, I always remember this sentence by Mark Twain that it's a classic, something that everybody wants to have read and nobody wants to read. I would ask all of you to honestly put a hand on your heart and think, have I read the MTP Act of India? If you haven't read it, I will very strongly urge you to read it. For me, it remains the one act in our country which empowers not only doctors to provide abortion safely, but also women to access abortion safely. It's an extremely elegant act. It's an extremely simple act. And as I said, it's an extremely empowering act and to a certain extent, even a protective act. What was the need for the act? The act came into being because the Indian Penal Code of 1860, which we inherited from the British Code, had two sections within it, Section 312 and Section 313 to 316, which criminalized abortion. That means anyone either undergoing an abortion or anyone providing an abortion was considered to be a criminal under the Indian Penal Code. The government of India realized that because of this, a large number of abortions were being driven underground. Women were resorting to unsafe abortions from quacks, etc. Because it's a proven fact that when a woman wants an abortion, she will go and get the abortion. It doesn't matter whether ultimately she finds a safe provider or an unsafe provider, but she will go and get the abortion if she wants. The government of India realized this and therefore set up a committee called the Shantilal Shah Committee in 1964. This committee worked for 2 years and then made some recommendations in 66, which resulted in the MTP bill being introduced in the Rajya Sabha in 69 and which was finally passed as the MTP Act in 71. What I'd like to point out here is the amount of time it took for the committee to start work, give the report, and for the law to get passed. And I think this is something which we have to understand very clearly. Whenever I speak about this, always somebody in the audience gets up and says, but why doesn't the government change this, change that, change this, that, and the other? And you can see the reason why it takes so much time for laws to get passed and laws to get amended in our country. Finally, this act was enforced nationwide from April 1, 1972. There is sometimes some confusion about what is the act, what the rules are, and what the regulations are. So the act is an act of parliament providing an overview of safe abortion and delegating certain authority to central and state governments. This authority is manifest by the central government in the form of the rules. But whenever rules have to be changed, they have to be ratified by each house of parliament. So rules can actually make very significant changes to the act without affecting the act itself, because modifying the act is a very long procedure, modifying the rules, not so much. The regulations are those framed by the state government and are only those related to opinions, reporting, and maintaining secrecy. So if your state is making rules for MTP other than opinion, reporting, and maintaining secrecy, then that state order actually quite supersedes the brief that is given to it by the MTP Act. As I already told you, this is a very simple act. It's a very elegant act. Please read it. It's also a very short act, quite easy to read. But in essence, this act tells you about who can do the MTP, who can undergo the MTP, where can you do the MTP, and when can you do an MTP. So it just answers and lays down the conditions for all this. And within the act, probably most of these things are reflected in Section 3 of the MTP Act. So let me take you through Section 3 of the MTP Act. So if you look at Section 3, Clause 2, Subclause A and B, it tells you when you can do the MTP. So you can do the MTP up to 20 weeks as Section A and Section B say. You can do an MTP up to 12 weeks on the basis of one opinion. And between 12 and 20 weeks, you need the opinion of 2 registered medical practitioners. When can you do this MTP? You can do it if the continuance of pregnancy would involve a risk to the life of the pregnant woman or grave injury to her physical or mental health, or if there is a substantial risk that if the child were born, it would suffer from physical or mental abnormalities to be seriously handicapped. So actually, there are only 2 indications of doing an MTP. under the MTP Act. But these indications are further clarified in the explanation to this. What is the clarification? That if the pregnant woman has a pregnancy which is caused by rape, the anguish caused by such pregnancy constitutes grave injury to mental health, and then the indication or the explanation or part of the act that is used most commonly to do an MTP, which is where a pregnancy occurs as a result of failure of any device or method used by any married woman. Now, that word is important, or her husband, for the purpose of limiting the number. Then they say that the anguish which is caused by such an unwanted pregnancy is presumed to constitute a grave injury to the mental health. Now, look at the wisdom of the lawmakers when they framed this. They did not say, ask the patient what contraception. They did not say, ask the patient why the contraception failed. They did not say, ask the patient since when she was using contraception. The patient could have been thinking about contraception at that time, and that is also perfectly fine to use this indication to provide an MTP. The operative thing to remember here is that this indication is restricted to married women. So if, for example, you have somebody who is, say, 20 years old, that means she is major, and she comes to you for an MTP for failure of contraception, don't write failure of contraception for that. Over there, the indication that you need to use is grave injury to mental health, not failure of contraception. The next part gives flexibility to the indications by saying that you need to take into account actual or reasonable, the foreseeable environment. Part 4 of Section 3 deals with age and consent. What it essentially says that you cannot do an MTP for a woman unless she is 18 years old and more. However, even if she is more than 18 years old, then she has to be of a sound mental mind. If she is less than 18 years old, before the POXO Act, you could still do an MTP with consent of a guardian. But now the POXO Act has come in and complicated matters for these women. Part B over here is important. Save as otherwise provided in Clause A, which is in women less than 18 years. So if you have a major woman, that's a woman more than 18, you can terminate the pregnancy with the consent only of the pregnant woman. You don't need anybody else's consent. You don't need the husband's consent, kaka's consent, kaki's consent, mama, mami, dada, dadi. Nobody else's consent is required. If she is more than 18 years old and of sound mind, her consent alone is good enough for you to go ahead and provide the MTP. If you want to provide the MTP, you need to do so in a place which is recognized by the government. And who recognizes the place? This place is recognized by the district level committee, where all the requirements and members of district level committee are quite well outlined in the rules of the MTP committee. The 2002 rules further bifurcated the requirements of first and second trimester MTP centers. This was seen as a very important step because now you could provide first trimester abortions, which are actually the large majority of abortions, in places with much less stringent requirements than what were there for second trimester abortions. I told you earlier that the rules are very important and they are a great way to make changes in how we provide abortions. Did you know that medication abortion, which, as I have said, accounts for the large majority of abortions in our country, is not covered under the MTP Act? We are able to provide medication abortion because of the rules which came in 2002, which allowed the use of medical agents up to 49 days. This has now changed. We are now allowed to provide medication abortion right up to 9 weeks of pregnancy. And medication abortion can be provided even from places which are not registered for an MTP, provided the person who is dispensing and providing the abortion displays a certificate. It's a simple certificate. It's not to be taken from an authority. The certificate simply states that in case there is a problem, that doctor who's providing the abortion from that facility has access to another facility in case of a complication. I will urge you to remember that at the end of the day, the medication abortion is still an abortion. The MTP Act applies in all respects. Consent is vital. Consent has to be taken in Form C. I cannot stress this enough. You can take any fancy consent you want, but if you've not taken the consent in Form C, then that consent is not really applicable for that particular patient. And of course, ultrasound is not mandatory. As of now, provision of MTP services is restricted to the allopathic stream of medicine. Even MBBS doctors can provide abortions, but they have to first undergo a certification training from a government institute before they can provide. Only MBBS doctors cannot provide second trimester abortion. Documentation and records, as I said, are important, particularly because these are supposed to be confidential. So the procedure to follow is that when a patient comes to you for an abortion, you have to enter her name in the register, which is supposed to be a secret document kept under lock and key, and then refer to her by the code throughout the duration of her MTP. That means if you give her a code, say XYZ, then in her indoor paper, in her discharge paper, and in all the other papers, she has to be referred to as XYZ and not by her name. As I already told you, this is an empowering act, this is a protective act, and this Section 8 is what protects us from any action which can be taken on us, provided if there is a complication. But you are protected if you follow the entire tenets of the MTP Act. So you have to be registered, you have to provide an MTP in a registered place, and you have to provide it as per the indications of the Act and within the time limits and the age limits defined in the Act. So I just like this sort of Section 5 example to show you how important words are in law. If you look at this, I have actually made this bold. This is immediately necessary. Now, I just ask you to read this sentence without that word immediately. Formed in good faith that determination of such pregnancy is necessary to save the life of the pregnant woman instead of immediately necessary to save the life of the pregnant woman. It makes so much difference. For example, that 12-year-old girl at 24 weeks, we could have easily said that doing an abortion at 24 weeks for that girl is safer than her going to term and undergoing a cesarean section. And we could have used Section 5 if that word immediately were not there in that section. So that's what the law is sort of all about. As any Harry Potter fan will know this quotation, when Scrimgeour asks Hermione, "Are you planning to follow a career in magical law?" She says, "No, I'm not. I'm actually hoping to do some good in the world." And really, this is the way we as doctors, we as obstetricians perceive the law. And sometimes I don't think I'm surprised about why we perceive the law like this. Because you have this great act, you have this empowering act, the MTP Act, and then other laws come with their unintended consequences and really strip the MTP Act of its empowering ability. Look at this. This is the POXO Act, a much needed act. There is no doubt that the POXO Act is a required act. But what the POXO Act does is that it does not recognize consensual sexual act even amongst adolescents. And we know that adolescents have sex. Moreover, the POXO Act penalizes and criminalizes anybody who either instigates, intentionally aids, or abets the offense. So, if, for example, you come to know of a case of sexual abuse, so let's take the example of a minor girl who comes to you and says that I'm pregnant. This minor girl has obviously had sex, that's why she's pregnant. And you are now having knowledge of someone who has had an offense under the POXO Act. You have to report this. If you don't report this, then you are wrong under the POXO Act. So what the POXO Act has done is, it has criminalized all sexual activity below the age of 18. The government has taken this my bap kind of protective attitude and actually infringed upon the dignity and bodily integrity of adolescents. The POXO Act, in essence, has conflated child sexuality with child sexual abuse. And this is a funny example of how the government has probably not been able to reconcile within itself the fact that on the one hand, POXO Act exists in its current form, and on the other hand, you have documents like this RKSK booklet, which actually talks about adolescent contraception. Just imagine you have the same government which says all sexuality below 18 is criminal. And the same government on the same website has a document which says contraception is something which is important for adolescents and they should have access to it. The question therefore arises is how do we start to reconcile this? And really, we are really working on this quite hard, and we hope to roll out an initiative soon to rationalize these acts. Of course, then we have the very famous PCPNDT Act. And the problem with the act is not the act itself, it's the way the act is implemented. Because of the way the act is implemented, anybody who seeks a second trimester abortion is immediately criminalized in the mind of an authority. Although there is more and enough data to show that the large majority, it's more than 80% of women who seek second trimester abortion don't do that for sex determination. We had filed a PIL in the Supreme Court, and this was one of the documents that we had submitted. This document was provided by Dr. Radni Contractor. And this is an RTI filed in Rajasthan. And if you will see this, they analyzed 46 lakh forms, 46 lakh F forms, inform the total number of pregnant women who have undergone illegal sex determination detected on the basis of information submitted on these F forms. चाही गई सूचना शून्य है. That means after analyzing 46 lakh F forms, they could not even detect one patient who underwent an illegal sex determination or a sex-selected abortion. So what in the world are we filling these F forms for? Of course, the restriction on late abortions is another story altogether. And this is something which I always say, that the question of abortion shouldn't be an issue in the political arena. When the woman has to make this kind of decision, she should see her doctor, not her lawyer. A lot of advocacy from a lot of stakeholders has gone into this. We have even gone to the Prime Minister's office and met officials within the PMO to advocate for this. And we have told them that all these changes in the MTP Act are urgently needed for the MTP Act to keep up with times. And we were delighted when in 2020 these amendments were presented to the Lok Sabha. I must caution you here to inform you that only the Lok Sabha has passed these amendments. These amendments still have to go through the Rajya Sabha. They still have to be signed by the President and gazetted. Only after all this is done will these amendments come into play. So the current practice has to be as per the old MTP Act. Now, if you look at the next few slides, Dr. Vidya, according to my timing, I have around 7 minutes more. Is that proper? Yeah? Okay, thank you. Yeah, I'll finish in 7 minutes. I'm timing myself, so no problem. Yeah. The lines in orange are the amendments which took place in 2002, and what is written in red are the amendments which will take place in 2020. So what are the amendments of 2020? A medical board has been constituted, and if you look at part E over there, section 2 part E, medical abortion has been brought into the ambit of the MTP Act. I told you that medical abortion is now permitted because of the rules, but now it has been brought into the Act. One of the more significant changes is over here. We are now going to be allowed to do abortions up to 20 weeks with a single opinion. There is no need to take two opinions between 12 and 20 weeks. But if you want to do an abortion between 20 and 24 weeks, then you need two opinions and you will be allowed to do it only for women as will be described in the rules which are to come. Another significant thing which a lot of people have missed is that in that line there is a substantial risk if the child were to born, it would suffer from physical or mental abnormality. That part about to be seriously handicapped is removed. So the bar for providing an abortion has been considerably lowered in the MTP Act, which is obviously going to increase choice for women. In a typical sort of a government or a bureaucratic thing, explanation one has moved to explanation two, and explanation two has moved to explanation one over here. But anyway, what is important here is that that part about married women for failure of contraception has now gone. You can provide uh, abortions for failure of contraceptions to even unmarried women if they are more than 18 years of age and of sound mind. The other amendments have mainly to do with the establishment of the medical boards, and the requirement of confidentiality has been made more stringent under the new amendments of the MTP Act. So this is an editorial, an op-ed I have written for the Ministry of Health and Family Welfare for the Government of India. It's not been published yet. They're waiting till the act actually gets passed, and then they will publish this op-ed in a newspaper or something. This is just to show that we have already started looking at the rules or what medical boards need to follow. So I was invited by the government of Maharashtra to frame the guidelines or the SOPs for MTPs beyond 20 weeks, because as of now, the law is for 20 weeks. And I have already presented this to the government and they have already accepted it. So in the last 4 minutes of my presentation, I'm going to briefly touch upon the practice of abortion in India. And of course, these are the preferred methods of abortion in India, and these are the WHO recommendations. What I would like to point out is that DNC does not find a place anymore under the preferred methods of abortion, and medication abortion and surgical abortions are complementary. They are not competitive. What is, however, true is that early abortions are safe. So whenever we plan any advocacy, whenever we plan any policy measure, it is important that we encourage women to come to us quite early. Everybody has heard about MVA. I hope that all of you are now using MVA. We all know how to use the MVA. The 2-3 important things I would like to say here is that when you're doing an MVA, there is no need to go and touch the fundus every time you're doing an MVA. The MVA works by suction. So even if you hold it 3/4 of the way into the uterine cavity, the contents are supposed to come into the cannula because of the suction pressure. When MBA was introduced, one of the doubts that was there in people's mind is that we were all used to that, mighty electric vacuum which used to stand in one corner of the OT and go gur, 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 gur. And how would this, small tiny syringe be able to create a vacuum which was equal to that big mighty machine? But if you look at the data, you'll find that the MVA syringe actually produces a higher vacuum than the electric syringe, till the syringe is 80% full. Is that a bad thing? No. According to me, it is the most important safety feature of the MVA syringe, because if per chance you perforate, and if you perforate using an electric pump, you could potentially suck out the entire viscera of the abdomen before you would realize. But with an MVA cannula, because the suction drops, once the syringe is 80% full, the amount of damage that you will do will be very small and limited. So, of course, as I've said, DNC finds no place in abortion provision. And this is some work we had done in West Bengal, where we had looked at sites which were still providing DNC. We talked to them, we trained them in MVA, and when we went back, we found that the use of DNC had come down quite considerably. This is the last part of the talk, and it tells you about medication abortion. You can look at the journey of the MA-related guidelines. There has been a sea change in the way the guidelines have gone about. And I've already told you a little about how MA can be provided. It can not only be provided from registered facilities, but it can also be provided from unregistered facilities. If you are qualified to do an MTP, you can display a certificate saying that in case of a problem, you have access to a place and you will be able to provide medication abortion. As I said, medication abortion is not covered under the Act, and it is the guidelines which actually cover the medication abortion. So for first trimester, you're supposed to give 200 Mifi. 48 hours later, give 400 misoprostol, and you can have the abortion done quite simply. So this is a comparison of the WHO guidelines and the Government of India CAC guidelines, and you will see that they are quite in consonance with each other. There is not much discrepancy in these guidelines, except for the fact that the WHO guideline says misoprostol can be taken at home. Facility visit is not required. The Government of India leaves the discretion to the provider. The WHO guideline says if the patient is convinced that she's had an abortion, then a follow-up is not required. That means she's not bleeding, etc. But the Government of India guidelines say that follow-up is mandatory. So I have just finished my time. So thank you very much again for a very patient hearing. It's always a pleasure to speak about this, and I'm more than happy to answer any questions if there are.
Yeah. Thank you, Jaideep. I think that was a very wonderful talk. And usually, I think how to use the MVP which you have shown. I think still maybe you remember some 10, 15 years back, a lot of workshops
MBA
were done all over. MBA workshops, were done. Probably now also, probably we need to do a rerun of those workshops. I think maybe in the webinar you could arrange one so that people can just anytime see it, and then so that
yes,
they get
and I'm sure we can do that.
So
in fact, there are a lot of there are a lot of resources available on the internet. If you, for example, just go to YouTube and say MBA, you will get a lot of authentic videos on how MBA is to be provided. But Foxy also should take this up on a very sort of an important kind of a step. I fully agree with you, Shanta.
So that, you disseminate the knowledge and everyone, instead of, if it goes from the Foxy, everyone will start actually see it once in a while and it gets re-registered in the brain. I think let's plan about it.
Maybe we can.
Has any of doubts? Yeah. Please tell Jaideep, you were.
No, I said we have a lot of videos which we had produced when MBA was introduced. Noza was the chair at that time.
I know. I remember.
That time. So I had produced a lot of videos at that time. Maybe I can dig them up and put them on the Foxy website.
Yes, I think that will be good. And now with this webinar happening, you can send a link also to all the members to relook at it.
Yes.
So there were some questions on the POSCO Act which Vindhya would like to ask you. Vindhya, you had some doubts regarding the POSCO Act and the MTP Act. Vindhya can unmute. Yeah. But the problem was, Jaideep, many people have this discrepancy between the POSCO Act and the MTP Act. See, we want to offer abortion services to all the women who come to us, unfortunately, even if it's less than 18 years, because we want to curtail all the, by so how is it that in this scenario we can help our young girls so that they don't have problems? So this is one big question among our obstetricians, gynecologists, when girls less than 18 years come with the wish to have an abortion. How do we proceed?
Well, unfortunately, with the way the POXO Act is framed, Shanta and Dr. Vindhya, the way that Act is written, the way the penal provisions of that Act are, it's not simply a matter of protecting the girl, it's also a matter of protecting yourself. So under that Act, if you come to know of a minor girl who's pregnant, she's obviously had an offense under the POXO Act, because the POXO Act criminalizes all sexual activity below 18 years of age, even if it is consensual. So if you get a minor girl, the ideal thing to do would be to report it to the police. Don't try to be large-hearted and, for the girl's sake and for the parents' sake or anything, go ahead and provide the abortion. The problem is that in our country, the way the whole legal system works, reporting it to the police is actually subjecting the girl to reliving the trauma again and again and again. So a reasonable solution could be to refer that girl to, for example, a medical college. I don't know about Hyderabad, but in Bombay, all medical colleges have a police constable stationed outside casualty. And if that girl goes to a medical college and casualty, then she will sort of receive all the facilities of the police in-house, if you will. So she won't have to go to the police station. She will not have to subject herself to waiting outside the police inspector's cabin and so on and so forth. Normally, the casualty officers will admit that girl for termination or whatever. And then in-house, the police will take care of registering the FIR, etc., etc., etc. I must say that in the few cases that we have faced, the police have actually been very considerate. And in the cases where I've given an expert opinion in a few cases on this, and when these cases have gone to the court, invariably judicial discretion has been used not to punish the adolescents who have committed the so-called crime of consensual sex. So I mean, the police and the judiciary are sensitive, but the way the act is written, it would be a bit of an overreach if you would just go ahead and provide the abortion without making any legal provisions or information and so on and so forth. Yeah.
I think that's a very valid point. Yes, Vindhya and Kiranmai or Dr. Rajalakshmi, do you have any questions you'd like to ask Jaideep?
Sir, hello?
Yeah.
Yes, Kiran.
I can hear you.
Yeah, sir, the word lunatic.
Yeah, it's been replaced.
Is there any specificity about that word that is very vaguely termed lunatic, like any?
It's the word lunatic has been replaced in 2002 by so it's been replaced, so there is no problem. And you don't, for example, under the MTP Act, to certify whether there will be grievous mental injury or not, you don't need a psychiatrist's opinion.
Okay.
Otherwise, you would never be able to use failure of contraception, because failure of contraception is linked to grievous mental harm.
Yes, sir, regarding consent. Regarding consent, if it is above 18 years and a lunatic, then you need a guardian's.
Yes. Then you need a psychiatry opinion. So, for example, in a circumstance of sound mind, we say, so if there is a girl more than 18 and not of sound mind, then you need a psychiatry opinion and the consent of her guardian before you provide the abortion.
Yes, sir. At our hospital, we have a police outpost, madam. Also, so generally we are informing the outpost and police and doing what is required.
Absolutely. Yes, absolutely. I think that is the right way to do the things. Yes.
Sir, what about more than 24 weeks? Suppose, as you said in first slide, once a girl is rather more than 24 or 28 years, unmarried, how to approach? Already we are approaching police, as our Kiran said, but to get a police consent and all, it will be delayed. In that matters, how would we proceed in case of...
Madam, correct me if I'm wrong, but the question is that if she is more than 24 weeks pregnant, then what will you do? Is that right?
Yeah.
So as of now, even if she is more than 20 weeks pregnant, because the 20 to 24 weeks is not passed from the parliament yet. So as of now, the barrier is 20 weeks. So if there is anybody who's more than 20 weeks, the Supreme Court has said that you need to go to High Court. No other court will do. And the police cannot give you permission. You have to file an affidavit. There is a template available, which I have helped the government of Maharashtra to develop. You have to fill the affidavit in that template. You have to apply to High Court. The High Court will then send that girl or that woman to a medical board. That medical board will then certify whether this abortion is required or not, is indicated or not actually. And if the medical board says it is indicated, the High Court will give permission. Nobody else, no lower court, sessions court or district court, nobody can give permission for this except the High Court or the Supreme Court. So as of now, even going to the police is of no value. So you go to the police only if she's a minor. If she is not a minor, if she's a major of sound mental status, then there is no need to go to the police. You go straight to the High Court.
Thank you so much for clarification, sir, because so many of our colleagues were in dilemma when patient was brought caught with 24, 28 weeks by the police, unmarried. So everybody is asking us. So you have clarified, and we are very thankful to you, sir.
Thank you. I would also like to make another important point that the problem here is not whether she is married or not. The problem is that she's more than 20 weeks. So, for example, if you get somebody who's more than 18 years old, is unmarried, and is less than 20 weeks pregnant, then only her consent is good enough for you to provide the abortion. So, I should clarify that. So, the barrier is not the fact whether she's married or unmarried. The barrier is the fact that she's more than 20 weeks.
Once they go to the court, how long will it take?
Exactly.
In the SOPs that I have drafted for the government of Maharashtra, we have said that the medical board has to examine within 48 hours and give an opinion.
That is the 2 days is okay.
Yeah.
Sir, actually, in our setup in government sector, we have Bharosa, sir, Bharosa centers, where judiciary and medical officers along with the judges are there. I think High Court cannot be delayed. If it is properly
it cannot be.
approached, it cannot be delayed.
Yes, absolutely.
I think Jaideep has answered most of the queries. I'm sure, Jaideep, the audience questions will also start pouring in by the end of the session. So if you get free when you deliver or anything, I can always ask you to just clarify those doubts.
Yeah. I will join back in some time.
Yes. So thank you very much for being with us.
Thank you. It was a real pleasure. Thank you again.
Yeah.
Thank you.
Bye. So, friends, now we have heard the wonderful talk by Dr. Jaideep. Now, can we have Dr. Rajalakshmi's CV slide session? Yes, Sana. Friends, we have seen the last 2.5 months has been a real dilemma. Don't you agree? Suddenly in the month of March, we were introduced to a new word, the lockdown, when the pandemic suddenly dawned on us. We never realized that what a pandemic is. See, when we were studying in MBBS, we used to read about epidemic, pandemic, but we really never thought that in our lifetime we'll see something like a pandemic. But pandemic came and the word like a lockdown came, and people started talking about lock-in, lockdown, and lockout. In this early part of the lockdown stage, which started the end of March and April, we suddenly found that every center was closed and there was a lot of dilemmas. And then they were worried about whether this COVID infection could spread from patients and in the elective OPDs, non-emergency OPDs. And there were so many dilemmas. And then the government and the Foxy GCPR and all of us actually came out with a guideline saying that we halt all normal OPDs and only offer emergency care. So for any other department, it's perfectly okay to stop their care for some time. But obstetrics will not wait for anyone at any time. So we realized that our department had to face the main dilemmas of having to deliver our women, be it lockdown or lockout or whatever. So in that situation, we found that in our own state of Telangana, we had our Osmania medical colleges where the 3 hospitals were there. You believe that in the month of April, in all that humbug of lockdown and all, our hospital have delivered about 4,000 women. And that's quite a big number. And simultaneously in that time, we did have a lot of private hospitals, which also went ahead and delivered many women who actually came in that particular month. So friends, in this pandemic era, how is it that we have actually stood up and we have provided the essential obstetric care in the public sector hospitals? This will be dealt by our own Dr. Rajalakshmi. Now, I have the pleasure of introducing my friend, Dr. Rajalakshmi. She's a superintendent and professor and HOD of OB-GYN of GMH, Sultan Bazar and Nilofer. All of these 3 big hospitals come under Osmania Medical College, one of the biggest medical colleges of Telangana state. It is more than 150 years old. And Dr. Rajalakshmi has been running this unit in the 3 hospitals very successfully, and we have to congratulate her for doing a wonderful job in this pandemic period. And to talk about Rajalakshmi, she's been awarded a lot of gold medals and appreciation time several times, about 18 times by the Chief Minister and magistrates. And that's making me a little jealous, Rajalakshmi. You seem to be having too much of gold in this era where we find that the gold cost is really escalating. And she's a good laparoscopic surgeon, EPL trainer, trained many medical officers in AP and Telangana. She's been nominated by the Lokayukta in the Twin Cities for medical employees and solved many disputes faced by women employees since 1998 till date, till the state bifurcated. And she has been actually very smart in doing an MD in hospital administration, which is very essential along with an MD Gynec degree. PG degree on alternative dispute resolutions, passed with distinction from Nalsar University. Well, that's really good. And worked on bed dynamics in relation to the finance and patient turnover. Got special appreciation by the AIIMS Delhi. Received a special officer for Honorable CM Sri KCR sir while fasting for separate Telangana state. And she has done a lot of research on safe motherhood, adolescent gynecology, congenital heart disease and pregnancy outcome, high-risk pregnancies and hypertensive disorders. And we know all this has actually come out in this pandemic era where the medical college has the privilege of delivering so many women safely. She's been a special member for the study of kidney disease and awarded the best teacher by Telangana state government. So Rajalakshmi, welcome to our webinar. We are very proud to have you, and we have to congratulate you and all your team members who have been working relentlessly in the public sector hospitals over the 2.5 months and delivering the best obstetric care to our women of Telangana. So we are very proud of you, and Vindhya and I both would like to congratulate you and your team for this fantastic job. And we are just waiting to hear from you how you have handled this in this pandemic situation.
Thank you so much for your kind introduction to me to the audience. And at the same time, good evening all of you, the audience also. Because my topic was allotted regarding the public sector and private on par with private sector, and I am heading the public sectors. I would like to talk rather than the OBGY specialty. My pandemic area limited to only preventive. Now what I have done is only preventive measures, nothing but preventive measures. Because as you said, madam, and first of all, let me thank all the OBGY specialty doctors and Foxy Association also to support us continuously. And special thanks for our dynamic President Shanta Kumari Garu. And second thing, and we are very fortunate to have our government administration also. Day by day, they are giving us very enthusiastic and also empowerment by giving moral support. That's the only thing that I would have done this. And actually, I am very astonished to see my statistics. All these days we were working, nothing about statistics. Today, when webinar, Aruna Suman has come and asked me to participate in webinar, I thought, let me have my statistics. When I gone through the statistics, on March 26th, we were locked down in Hyderabad. And my SBH hospital is 1934 established hospital with 160 bedded. But we are merged with King Koti Hospital maternity unit. And successively on 1st April, even Gandhi non-COVID center was merged with us. So we have a lot of burden while getting all these cases. More than that, so Gandhi non-COVID patients also are coming to us. And government has issued our guidelines to cut short the OPs by taking some preventive measures. What I could have done, the preventive medicine is the first best thing. So I have cut short the OP procedures, and usually our OP will stand at 1,000 to 1,500 per day. But what I did, only after 32 weeks, I have taken the cases, and we ask the patient whenever emergency arises to attend in labor room or emergency wards. Like that, our statistics for 2.5 months, from March 26 to May 31st, I have seen 18,622 OP patients. I wonder, none of our patient was identified as COVID, nor my staff. I am proud of that, because what I did was I could not do anything else except making the patient in standing line, and real emergency patients was given OP cards. And second thing, I asked the patient to cover their mouth with mask. We only supplied the cloth mask because we don't know what the guidelines, every day changing guidelines. We could not follow the real guideline. The only thing is prevention is the better than the cure. That was my motto. And I have cut short the OP like that. And even doctors also, I have made into zones. Some part of the doctors, we have 10 as well, 6 associate professors and merged a King Koti civil surgeon specialists, including those are the cream of my hospital, and were posted to OT, only operation theaters. And the rest of the people, we have 10 working doctors as night duty doctors. What they have done, out of 10, I have made 5 doctors constantly sit in OP, so that only 4 cubicles are maintained and outpatient is closed. And once the patient comes inside, she has to quit from that hospital outpatient gate only. So there is no inflow into the inpatient department. Like that, we have cut shorted, madam. And coming to the inpatient department, we have made a triage where every patient has to be tested like contaminated case. And second thing, we are in large numbers and patient is also in large numbers. Due to space constraints, we could not maintain the physical distance. How far we can do, that much have been implemented. And every patient who comes to us with breathlessness or fever, we have a sort of not isolation, but a keeping distance. Once one patient was exposed to one doctor and one PG, that patient will be dealt by that doctor. And I have made all the employees into 4 groups. Out of 4 groups, one group today they will work for 24 hours. After that 4 days they will be in quarantine period. They will need not come to hospital. And second day, second group will come. And those people will work for 24 hours. And like that, I made the employees into 4 groups, madam. And coming to the patient part, so expected ED patients. So suppose tomorrow they are expecting, or within this week they are expecting, we have to admit the patient. No inductions as such. Immediately, if there are previous sections, we used to post as elective sections. Those elective sections are almost 25 to 30 per day. The total admissions of our hospital, who need real emergencies, are 70 per day, 60 to 70. Out of 60 to 70, 30 sections were dealt by our associate professors who are maintaining in the OT itself with their own precautions. And coming to the normal deliveries, our duty doctors who are on night duty, those are assistant professors, they were made into 2 teams, 2 people at a time with the 3 PGs in a daytime. And they used to take over the labor room in the morning till next day morning, so that they are exposed only to a few number of patients. The patient turnover is only 2 to 3 days in case of section, and in case of normal delivery, 24 hours, especially if they are complicated cases. And we used to get referral cases because government has issued a GO. This is a higher center for Telangana state. Hence, I used to get from Hyderabad, Khammam, and like that. And those near miss cases, if I look back and saw, it was to my surprise 497, madam, near miss cases, out of which only we had 2 maternal mortalities, all these 2. So this is my proudness on behalf of my staff, because they stood after me. Because I am the leader, I feel a doctor being an obstetrician, one should have a quality of leadership, communication, and spokesperson. So all the 3 qualities we have exhibited as we learned in preventive medicine. So third thing, the patient turnover also, because our beds are only 160 sanctioned, but we made it to 400. But every day the turnover is, discharges also same, 100 to 150 discharges per day we used to do it, including myself writing the discharges, so that contamination is less and exposure is also less, true for our staff. And third thing, the complicated cases which are dealt, almost eclampsia cases we have dealt 1812 cases, madam, and in that 145 Helios and portal hypertensions and cardiomyopathies, we have dealt 12 cases, and nothing resulted in maternal mortality. That is 24 hours dedicated work by my team and myself, madam, and including deaths. Really, those are unfortunate because they were referred in late stage, and which resulted in cardiovascular accidents. This is the planning which I have done, madam. Today, I am really glad that obstetrics is the department which we could not close it, rather than we cannot cut short. And third thing, we have very bad cases, even gynec cases also, coming with ruptured ectopics, lasting for pelvic abscess, and again interstitial perforation. Like that, I have dealt 4 cases. And we never had any mortality. We have injured the internal iliac artery also, or external iliac artery also. With the help of our Osmania surgical team, we got out of that complication, madam. So even this lockdown period is very bad to the patients also, because in time they could not reach the hospital. Whatever the case, we are getting here all in late stages. So we need a dedicated team for that. And second thing, at the same time, we should not expose to ourselves. Hence, what we have done is, we were dependent only on our clinical knowledge, because we are not supplemented and neither we have lab facilities also. Out of these admissions, which are 5,000, 5,619, 20 to 30% patients are presented with breathlessness, almost synchronous with COVID. But we have to identify which breathlessness is this, because we cannot refer the patient as a COVID, because almost they came in labor, and this is obstetric emergency, is more dire emergency rather than COVID. Hence, what we did, all the breathlessness cases, though my staff were very worried, I used to stand in front of that team, and we used to segregate which type of breathless is this by ECG, and no echo for us, nothing, only clinical. What we have to do, we used to admit before day breathlessness, we used to make them put her on some antibiotic and some nebulization, then next day morning under antibiotic coverage, we treated like infected case only. Then after delivery, we used to send to Usmania. Like that, we have referred 12 cases. Out of 12 cases, 2 turned out to be COVID, but they were survived with all the other complications. Like we had last week also one portal hypertension with splenomegaly and bilirubin, and is 20 above, and we delivered her normally. Later on, she had shown signs of encephalopathy. Immediately we shifted the patient to acute medical care of Usmania, where our ancillary department of general medicine has taken care. They thought it's a COVID case because of X-ray chest, some shown opacities. Today she is very fine. She came out of that difficulty, and now she is very happy, madam. With this, my message to the obstetricians are a physician and a surgeon, and also a community leader, because without us, there is no community at all. Second thing, we are very glad fetuses are not infected with COVID. That's a God's grace. Third thing, because being a community leaders, we are the pioneers for the society. Hence, we have to segregate the pandemic conditions along with our systemic conditions, so that I think we can have a brave warriorship like this whenever we are actually fighting with unknown enemy. We don't know the prognosis, we don't know the disease courses. Every day one new guidelines, every day the other code guidelines, everywhere one says PP kit, one says if you have PP kit, you will drench like anything, you will go like this. And one more thing, what I did, madam, I have whether I don't know what have raised immunity in my staff. 24 hours when they are working, I supplied breakfast, I supplied all spicy food like vegetable biryani, dal rice and bagara rice, whatever they could eat. In the night also lemon rice, because somebody is saying vitamin C is more important to, so I don't, what not nonsense. So all the 3 months, I have supplied the food, whether they ate or not, it's my duty, I thought. And every time I go around, I see the my staff, what they are doing, whether they are maintaining physical distancing or not, because our doctors, one patient comes, just they fall on the patient. So I used to go there, I make them to stand apart. Even on case sheet also, sometimes they keep blood packets, and sometimes even personal care, leaving the gloves, mask, and throwing everywhere. So I made 2-3 classes to maintain the social measures and all, and preventive measures. And I every day I gave the advice to go have bath with hot water, not cold water, hot water. Every day I used to insist, madam. Like that, today in Telangana state, we have done a good job. Unfortunately, some of our colleagues were down with the symptoms, but God will take care of their services. And especially I thank my SBS unit, Out of all these queries and complications, one single doctor was affected, even single staff was not affected, madam. That credit goes to my unit and God. And especially I thank Shantakumari madam to give this opportunity, and she's a very dynamic leader of our Foxy, and let us have all the webinars like this. And this is a sort of encouragement to the, now as an obstetrician I'm not talking, as a basic doctor what I'm talking is, better have your own strategy regarding when a pandemic is uh, appears like this, so that social preventive medicine is more important rather than our obstetrics. I think so. With this, I conclude, and all the viewers, please, what I told is the only your cleanliness and godliness, so nothing else. Thank you so much, madam.
Thank you, Dr. Rajalakshmi. You really did a fantastic job. I think we need to give you a big clap hand to you and the whole team. See, as she has rightly put, we really don't know what is right, what is wrong. The COVID pandemic just struck us out of the blue, and then we tried to do what was the best. And obstetrics never waited. You have delivered 4,000 women in 1 month of April, 4,000 plus women. And of course, I'm just talking about April. And that shows the commitment of you and your whole team. So I congratulate all your team members. We have some of them, Archana, Kiran, and of course, Aruna is from all of them. And see, what point I like this about Dr. Rajalakshmi's talk is, she did mention about one point about giving good diet to the doctors and the staff. See, these are small things, but that's very important, because in the whole bargain of trying to save the women, you're not taking care of your physical needs, your immunity. So that was a very positive, proactive way, I think, which has helped all of your team members to cope up with this. And again and again, I want to congratulate the whole team. Please convey our best wishes on behalf of Obstetrics Society of Hyderabad and Foxy to all the members of our public sector hospitals, and of course the private sector hospitals also, who are also delivering women. And we are very proud of all of you and all of us. Thank you very much.
Thank you so much.
Vindhya, do you have any queries or any questions to Rajalakshmi?
Nothing, but I'm amazed at the work they are doing. Congratulations, the whole team, all the government doctors. I think we really appreciate all of you. Good luck to all of us.
Yes, after the pandemic, we will definitely have an when we can actually meet again, we will do a real get together of all of us, and so that we can personally congratulate you all on the wonderful job. So thank you.
One more, madam. Yes. I am sincerely apologize my team. Sometimes they may think I'm very harsh also, because every day asking them to go for a section, or every day asking them to go for OP. But unfortunately, there is nothing in my hands. But I have done my best by giving them 4 or 5 days attested leave once they work like that. I have divided into groups, and some may be anointing, some may be, they may be. Most 80% will be disgusted, because we are also one among the public. So what public thinks, we also things like that. And second thing, our hospital is in the center. Every day we used to have quarreling patients. Every day we will have quarrel. And so I coordinated with police also. So even SI used to do rounds. Madam, after you came, we are having so much of trouble. Even in spite of that, we used to fed that police people also. We made our team and we got it, madam. And sincerely, I congratulate my team, and sincere apologies for my team also.
No. As you said, you were an obstetrician HOD, but you have implemented. What we needed is the public sector involvement. See, prevention. The SPM part of it, the preventive medicine, we never realized the importance of SPM subject when we studied. But if you look at the way we handle things, prevention is always better than cure. If we had tried our best to prevent the infection to come into the country, probably would have been more successful. So this has started the letter, and it's okay. You may have to act, sometimes to get the best, you have to act tough. So I'm sure your team now will agree with this. Archana, what is your comment? You may not unmute yourself.
True leader should always be tough.
At midnight also, if we call her, within seconds she will be in the hospital, and she will be doing work without getting tired even for a minute. So we get so much encouragement, because she is there midnight, 1 o'clock, 2 o'clock, anytime you can call her.
That's very good.
Can I add?
Love you, Archana.
Thank
Can
you.
I add?
Yes, Kiran.
Madam, one or two things is when the pandemic broke out, especially when the Jamaat thing came, we were all really, really scared. So everyone was focusing on PPE, rightly so. But the other day I realized the bio-waste disposal. See, use PPE, you throw it away. The bio-waste people disposal people also are on ships. They're also overburdened. They come in instead of 1 in 2 or 3 days. Sometimes they may be delayed. So where do you put all that waste? So that injudicious use of unnecessary paranoid way of using PPE is one thing which she discouraged. And as Archana said, if I am not wrong, Madam has been in hospital since 2 days. Yesterday night, the day before, for one case throughout. That is there. Like if I am dealing with a very bad case, I am 100% sure that she will come running.
Thank you.
That mental,
Yeah,
like,
one more thing I want to add.
English is working so hard, so we are also motivated to work hard. That is.
And madam arranges everything. It is say if blood is needed, I need not panic because madam is there to arrange. So that helps a lot.
Anything she's there.
Too big. She was having 2.5 hemoglobin. She has come from 5 private hospital and including one government hospital. But I was not worried because I knew madam will be there on my side. So doing the case and all brings lot of confidence when madam is around.
Yes, Archana, you are absolutely right. So when you have your the main boss around, you feel more motivated. And thank you, Kiran. Now I'm happy at least after 2 months you have come to accept my way of thinking when I did say don't only talk of PPE, don't talk of PPE.
There are many other things.
When the pandemic broke, people were very angry with me that they said you are talking only for the government. You are so pro government and you are talking PPEs are not there. But you have to understand
there are other very important things also.
Yes, it is. You have to look at it as a whole, not as an. Don't have tubular vision. Holistic view. Use what you have. Use your HIV.
What Madam said. It's the local strategy which is important.
Yes. So I'm happy.
Guidelines and you have your own strategy depending on your resources, your staff, your needs.
Thank you, Kiran.
Yes. So I'm very happy that.
Regarding PPE kits, everybody was annoyed. But the other day I took meeting, I told PPE kit because of this, you will be sick and disposal is also very great job for us. So that then I thought I have to motivate them. But unfortunately, my feedback is they were unhappy. But today I'm feeling their faces very wide.
Ma'am, like our strategy has been proved right. So we have thousands of women and then we're safe till now.
And I'm very happy, madam. None of us, our doctors and our children, PG children, and including our staff are negative, which was very greatest job of our subordinates and team.
We are very happy. And as Archana told that you were there with them, I still remember an incident. We spent a whole Sunday, both of us, Rajalakshmi and me, trying to save one life, and that patient is perfectly okay. So one whole Sunday we spent together in the OT, if Rajalakshmi remembers. Yes, thank you. And now we have more than 1,000 viewers now who are viewing the webinar. I'm sure all of them also are enjoying this webinar. And now we go to Dr. Archana. The mic is yours. You can go ahead and please introduce our next speaker, Dr. Kiran Mai.
Dr. Kiran is Associate Professor, Osmania Medical College, and she has been an active member of Obstetrics and Gynaecological Society, being Joint Secretary to Secretary and Vice President, and she has been in the Adolescent Committee, and she is very actively involved in the academics, including near-miss cases, nodal officer, and maternal mortality assessment. So, welcome, Dr. Kiran Mai.
Thanks, Archana.
I think Archana's voice was not very clear. Friends, we have great pleasure in introducing our own Kiran Mai. Kiran Mai is not new to the OGHS people. We have been seeing her work very actively, right? I have first met her during the AICOG time when Indra madam said, now you want some team people to work for the AIC. I said, yes, madam, we need all the younger people. Then she said, I'll bring my students, some of them. Then that's where I met actually Kiranmai, Aruna, Padmaja, and rest of them. Afterwards, Archana and Ananta and all these people we had met through the AICG times when we used to spend almost the whole of 1 year in the OGHS office every day and evening. We used to have, like how Rajalakshmi was supplying food, I was arranging lunches and events. So that actually bonded us together and we worked together. And from AICOG to so many other conferences we were doing. So every year we do a big conference. So this Kiranmai with Vindhya, Krishna and all the team, has been working very hard with Aruna Suman and all. So we're very proud of you, Kiran. And I know that MMR and abortion, all the laws for women's health are very close to your heart. So I wish you all the best, and I'm sure that you will be joining Foxy to work in a better, more stronger way so that you can help the women of the country. Yes. Now you're going to share with us the topic on RH isoimmunization.
Thank you, madam. It's really an honor and privilege to have stalwarts from Foxy and a very dear Shanta madam and our own Rajalakshmi madam with us today. It's more like a home affair at OGSH with my dear friends. So without further delay, the topic today allotted to me is RH isoimmunization. How to manage the RH sensitized pregnancy. So we used to call it as RH negative pregnancy, then RH incompatible pregnancy or RH isoimmunization. So basically I would like to tell about a little modification in the nomenclature. It is now better called as red cell alloimmunization, and a sensitization is a better word than incompatibility. And we used to say hemolytic disease of newborn. Now with ultrasound and the invasive fetal monitoring and the fetal medicine units have made the antenatal detection of severe anemia in fetus, not the neonate, a reality. So that is hemolytic disease of fetus and newborn. So we have around 2%. We all know that the Caucasians have around 15 to 16% of RH. Basically, I'm dealing with D. Though there are C, E, KEL and many red cell antigens, but basically most important is the D. So we'll be dealing with mostly D, and the management also is, except KEL, it is the same for other antigen sensitization. So we have, as you all know, two commonest systems. One is ABO and the rhesus system. ABO is AB, ABO, and whereas rhesus is C, the smaller C, D, E, and E and G. There is no small d antigen. So the letter represents absence of D antigen, and it is the most immunogenic. But it is interesting to note that after the RH immunoglobulin injections that we are giving, the anti-D has come down to 19%. It is not most common RH alloimmunization. It is anti-E which is most common now with 31%. And the incidence of hemolytic disease of fetus and newborn with all this immunization is around 1.2%. This is from a tertiary unit in the West with around 8,000 pregnancies. So you all know the pathophysiology. It is basically the paternal RH gene. If it is the partner is homozygous, then all the children are RH positive. There is no doubt about it. Whereas if the father or partner is heterozygous, then we have half of the children who can be RH negative, then half of the children who can be RH positive. So basically the first, we all know the basics. It is the sensitization, that is feto-maternal hemorrhage, which occurs in the first pregnancy or with an incompatible transfusion. As little as 0.1 ml of RH positive cells have been documented to cause RH sensitization. A small personal detail here. We siblings are 3 and we are all B positive. So when my mother had undergone hysterectomy somewhere in her late 40s when I was a medico, to our utter surprise, we noted that she was O negative. So I didn't understand really what was going on. So basically the pathophysiology says that there are responders, there are non-responders, there are hyper-responders and there are hypo-responders. So up to 30% of people can be non-responders. They never develop RH incompatibility even when challenged with large volumes of RH positive blood. So the feto-maternal hemorrhage in pregnancy during the antenatal period, it is 10%. During delivery, it is 90%. But the fetal RBCs have been detected in the 3 trimesters without an apparent predisposing factor. Initially, the first sensitization is IgM antibodies, but they don't, being bigger, they don't cross the placental barrier, so they don't cause much problem. But once the sensitization happens, within 6 weeks to 6 months, IgG antibodies are formed, which can cross the placenta, and now the problem starts. So the firstborn infants with Rh positive blood type are not affected, and it is the short period of this exposure is insufficient to produce significant IgG antibody response. Now, what happens? Now, for the second pregnancy, the second baby, if it is Rh positive, now the mother produces IgG antibodies, and the type of hemolysis is not the intravascular hemolysis, because this IgG lacks to bind complement. So what happens is the extravascular reticuloendothelial cell hemolysis, where the destruction of fetal red cells occurs in the reticuloendothelial system like liver, spleen and all. Because of the hemolysis, there is fetal anemia, there is excessive of heme formation, there is excessive formation of bilirubin formation. This heme and bilirubin are neurotoxic, but placenta and mother protects the child in utero, and the baby's extramedullary erythropoiesis goes on stimulated, and immature erythroblasts are produced. That is the reason why it is called as erythroblastosis fetalis also. But once the child is born, the anemia as well as the bilirubin, which causes kernicterus, the brain damage, we have a lot of losses. So hemolytic disease of newborn and HTFN. The sequence is anemia, the hepatosplenomegaly, heart failure, eventually because of anemia, with ascites, edema and pericardial effusion. And then hydrops fetalis. This is the commonest feature which we used to see when we were younger, maybe 2 decades or 1 decade back, in the ultrasound with the Buddha sign and all. This is a late and last event when this occurs when the hematocrit falls below 15%. This is just an event which is impending the fetal death. Again, here nature is little partial to the female fetus. The male fetus is 13 times more prone for this hemolytic disease of the fetus and the newborn. So the risk and severity of sensitization response increases with every pregnancy. Suppose we don't give the anti-D, the risk is 16% after 2 deliveries, whereas with the prophylaxis, it drops to 0.1%. So that is the protective effect of anti-D. But this risk depends, as I have told, on 3 main factors. One is what amount of blood volume is hemorrhage or transplacental hemorrhage is occurring. What is the mother? Is she a hypo, hyper or non-responder? Then what is the status of the ABO incompatibility? If the mother and child are ABO incompatible, it is quite protective and the risk drops to 1.5 to 2%. So what is the management? So once the mother comes with an Rh negative blood group, we need to ask the detailed history of prior blood transfusion, blood type of patient and the spouse, and all the previous pregnancies, outcomes and interventions. If she has a history of hydrops or an affected fetus, which surely indicates 90% of recurrence in the present pregnancy, whether she has been administered Rh immunoglobulin previously, what is the mechanism of injury if there was a trauma during pregnancy, any vaginal bleeding, prior invasive procedure, and then abortions, any amniocentesis or chorionic villus sampling, any pelvic trauma, antepartum hemorrhage, any IUFD, then multiple gestation, manual removal of placenta, ectopic pregnancy. This is all the positive history that we have to take from the patient. So how do we manage? So first is, if she is not sensitized, we have to prevent this alloimmunization in Rh negative unsensitized women by treating her antenatally. If at all she is sensitized, we need to detect the fetal anemia in this sensitized woman before damage occurs, and we have to rescue and retrieve the fetus. Then this sensitization, we all know, as it is determined by the indirect Holmes test, otherwise called antibody screen. So this is a flow chart, a very simple, which we all know by heart, that is mother negative, father positive. We do antibody screen at 20, 24 and 28 weeks of gestation. If it is negative, this part again, it is, this is conditional to the financial resources, whether to administer at 28 weeks, 300 micrograms of immunoglobulin. Ideally, we have to. And at delivery of the baby, We check the RH status of the newborn. If it is negative, no further treatment. If it is positive, we do give 300 micrograms of anti-D within 70. This is a standard protocol. This 300 micrograms covers 30 ml of fetal-maternal hemorrhage, which is quite a big, moderate amount. Where if she is positive on the titers at any of this time, we have to treat her as a sensitized pregnancy. It's entirely a different matter altogether. So this is the ACOG level of evidence for various indications per administration of anti-D. Then some few tidbits about RhIgG administration, like if delivery is planned within 48 hours of amniocentesis, defer till delivery, don't give it. If the delivery occurs within 3 weeks after a procedure like ECV, then a repeat dose is unnecessary unless a large hemorrhage is detected. Suppose there is a large maternal hemorrhage, this 300 micrograms is not going to be protected. We have to calculate the dose, and then we cannot administer 600 micrograms of RhIgG, all the dose at a time. So 600 micrograms 8th hourly until the total dose is achieved. Then what are the special conditions? Abortion, 5% chance of sensitization. Invasive fetal procedure, 11% of sensitization with 300 micrograms recommended. APH, again 300 micrograms. And if there is a 12 weeks gap is there, then again repeat. ECV, again 6% chance, dose is 300 micrograms. Then again during delivery, if she is not a sensitized pregnancy with titers not documented, so we need to consult with neonatologist. If we have to do MRP, manual removal of placenta, we have to be very gentle and careful, and use only that is, nothing to tell especially that we always use Rh negative blood. Early clamping of umbilical cord, we don't want overload of this sensitized hemolysis to occur. Leave a long length of cord because neonate may require a treatment for hyperbilirubinemia, about 15 to 20 centimeters. Then coming to the postpartum management, again involve the neonatologist. Send the cord sample for ABO Rh typing, direct Coombs test, hemoglobin, hematocrit, bilirubin levels, and peripheral smear. If the baby is negative, there is no further intervention. If the fetus is positive, you have to determine ideally the dose of RhIgG to be administered by the 4-step laboratory procedure. Administer within 72 hours, but if it is missed, you can give it as late as 28 days. The principle is don't deny even if it is delayed. So, okay, generally the 300 micrograms covers 30 ml of whole fetal blood or 15 ml of Rh positive fetal RBCs. But we need to do a 4-step lab test. So this is the 4-step laboratory procedure is, first is rosette fetal RBC screen, which we are not generally doing, but ideally if there is a major hemorrhage, we have to do it. This is a qualitative test which shows fetal RBC sensitized. If positive, we have to calculate the percentage of the cells by acid elution test. This percentage has to be multiplied into 50, the factor of 50 to know the total fetal RBCs. Then comes the calculation of the dose to be given within 72 hours. Once you calculate this volume of FMH, divide by 30 because 30 ml is 300 micrograms or 1 vial. If the volume of FMH by 30 gives the number of vials of Rh immunoglobulin to be administered. Suppose if on KB stain it is 3%, 50 into 3 is 150 ml, by 30 is 5 vials, and additionally 1 vial because generally there is undercorrection or under treatment, that is 6 vials. So this is how you do ideally, how you should do ideally. This is a positive rosette test, and this is acid elution. The ghost cells are the maternal cells. This is the fetal cells RBCs. We can clearly know the percentage of the fetal cells here. This is a direct Coombs test which is done in the fetal blood. I'll not go into the details. Okay, then coming to the management of sensitized pregnancy. Now we have dealt with a non-sensitized pregnancy where the titers are negative. Now a sensitized woman. So now from the history, if there is a history of an affected fetus, again the management jumps to more invasive or more serious fetal surveillance. If there is no prior history of hydrops or a fetus baby getting affected, then we go with the maternal antibody titers. So we determine by doing an ICT or indirect Coombs test on the maternal serum. then this is the sorry for the crowded slide, but I'll try to tell. Management of sensitized pregnant Rh negative women. There is no history and previous history. We'll examine first this part of the slide, that is no previous history of affected fetus. Then you identify the ABO and Rh group of the husband. If negative, no further testing. If positive, then go for the antibody titer. There is a critical antibody titer. A critical titer is defined as anti-red cell antibody titer associated with a significant risk for hydrops fetalis. Most centers use a critical titer as between 8 and 32. You decide for your center, go for a single lab, have standardization. Suppose if the antibody titer is below critical level till 36 weeks, continue your pregnancy to term, but don't allow to go post-dated. If it is beyond critical level after 34 weeks, deliver, give steroids, deliver. Then if it is beyond critical level before 34 weeks, now comes the dilemma. The lung maturity is not there, your baby is getting affected. Now, there are 4 options depending on your center, on your expertise, or on the resources that you have. Basic thing is the ultrasound examination of the fetus, which we used to do maybe a decade back. Then came the amniocentesis with the Lilly's curves and the Queenan's charts and all, where the optical density at 450 nanometers was assessed, and then zones were given. And once the baby is in the zone 3, it has to be delivered, and baby is already in risk for fetal hydrops. Then the boon is really the MCA Doppler. The peak systolic velocity of MCA Doppler is such a beautiful boon. Most of the centers and most of us are going for this if there is antibody titer beyond critical level before the fetal maturity. Then comes the percutaneous umbilical cord blood sampling for hematocrit and RH and all, which are in the domain for fetal medicine units, which are experienced and established. Okay, this is for where there is no history affected, but with increased titers. Suppose there is a previous history of affected fetus, you can't depend on the titers. You are not going to go for critical titers or antibody titers. You are going to either amniocentesis, MCA Dopplers right away from the beginning, from 18 weeks onwards, or higher cordocentesis and all. You have to decide early. So one thing is, if we determine the fetal blood type as early as possible, then we are quite safe. This is all indirect way of, knowing whether the baby is negative, positive and all. Are there any easy options? So we had cord blood sampling, which was invasive with fetal loss, amniocentesis with DNA testing, which was done in 1990s, and then determination of the, paternal genotype with, whether homozygous and heterozygous and all. But one interesting recent advance is the maternal, circulating cell-free fetal DNA from the maternal blood. So this is non-invasive, this is maternal blood sample that you are taking, and from 10 weeks onwards, it is 99% accurate in case of Rh positive. Only in Rh negative, there is a very slight, condition about, is it mother's cell that it is amplified or not. But this is a very, very promising and non-invasive test to know the fetal blood typing. Once you know the fetal blood type, more than half of your job is done. So coming to the invasive procedures, one is amniocentesis, which we all, read at least in theory about the Lilly's curves and Queenan's curves and all. But it is with the advent of non-invasive with MCA Doppler, more or less MCA Doppler has replaced this. Then coming to the fetal blood sampling and checking fetal hemoglobin level, this is a higher mode in the hierarchy when there is reserved for patients with a cutoff of peak systolic MCA Doppler of more than 1.5 multiple of median. This is regarding invasive procedures. So non-invasive or basic ultrasound, which shows hydrops fetalis. Hydrops fetalis is defined as presence of fluid in at least 2 fetal compartments like scalp edema, pleural effusion and ascites. When hydrops is present, the HB deficit of 7 to 10 grams from the mean hemoglobin value for the corresponding gestational age can be expected. That is end stage of fetal anemia, and survival with intrauterine transfusion is markedly reduced when hydrops is there. So no other, they have tried for, measuring fetal splenomegaly, hepatomegaly, various other parameters, but no other parameter in basic ultrasound has been useful in early prediction. Coming to the MCA Doppler velocimetry, it's an accurate and non-invasive screening tool for detecting moderate to severe fetal anemia with a sensitivity of 100% and 12% false positive rate for anemia. It has resulted in 80% reduction in invasive testing, that is amniocentesis and cardiocentesis. And it is, but these are the limitations: not useful before 18 weeks because reticuloendothelial system is too immature to hemolyze cells to cause anemia. Why does the Doppler MCA peak systolic velocity increases? Because of decreased viscosity and hyperdynamic circulation. Archana, am I running out of time? You just tell me.
No, it's good. It's
2 or 3 minutes. I think I've come almost to that. Not a reliable predictor of severe anemia again after 35 weeks. And again, when the baby goes for intrauterine transfusions, after the second transfusion, the MCA Doppler is again not useful. It is found to be similar or better than amniotic fluid OD415 prediction of anemia. This is one picture which shows. Again, the technique and all, I'll not go into the details. The fetus, the head of the fetus is in the anteroposterior diameter is in the transverse position. So the middle, the circle of Willis, either posterior or anterior, middle cerebral artery, whichever is accessible is chosen with least angle of insonation. I'm not a radiologist, but we need to follow certain techniques. Then results are, if it is mildly affected fetus or unaffected fetus, it is normal MCAD, and Doppler has to be right from 18 weeks. It has to be repeated monthly if it is normal. Deliver at or near term after lung maturity. This has a low risk of IO. You can be rest assured. If your MCA Dopplers are normal, you are rest assured. Then moderately affected, it will be hovering around 1.5 MOM. So you have to repeat 1 to 2 weekly, not monthly, and deliver as soon as lung maturity is obtained. So then we need to give steroids in this case. When MCAD Doppler is more than 1.55 MOM or has evidence of fetal hydrops, fetus needs help to attain lung maturity before delivery. So this is the category which has to be rescued and which has to go for higher fetal medicine units, that is severely affected with MCAD more than 1.5 MOM. These are the spectrophotometric charts of lilies and quinons. Then I have come to this. Okay. So now if it is MCA PSV is more than 1.5 and above, the options are: do you have facility for fetal blood sampling and amniocentesis? Then you refer. If you have a fetal medicine unit which is well versed with these techniques, then go for fetal blood sampling and evaluate and consider intrauterine transfusion. So what is intrauterine transfusion? We go actually into the amniotic cavity. If it is anterior placenta, go through the placenta. If it is posterior, we avoid the placenta. We go into the umbilical vein at the level of cord insertion into the placenta. It is very easy to tell, but how it is. Then the sample is withdrawn for hematocrit, bilirubin, and everything else. Then the transfusion is given to the fetus. It is carried out between 18 and 35 weeks. It may be given intraperitoneal if you can't give intravascular. ORH negative packed cells with HCT of 80% is used. Amount to be transfused in ml is gestational age minus 20 into 10, where the gestational age is more than 20 weeks. You can go for 2 or 3 transfusions depending on the necessity and maintain the hematocrit at around 30%. So is it, this is a, what I have described. It is given into the umbilical vein. Is it totally safe? In experienced centers, it is 91% success rate with 2 to 3% of fetal loss. And in the neonates, there was observation of 4% of neurodevelopmental issues. That is 4%. And then coming to the postpartum management. Okay, you have done either critical titers or you have done MCA Doppler or your center has done intrauterine transfusion. Now the baby is delivered. The problem has not ceased yet. So the baby again has to be admitted in NICU. And again, the exchange blood transfusions have to be going on when the baby is, because it takes time for the antibodies and all. So in moderate to severely affected neonates and along with phototherapy. So this is a summary slide. Basically what I have been telling, I'll go to the second half of this chart. So if serial MCA Dopplers every 1 to 2 weeks, if the velocity is less than 1.5 MOM, you continue the pregnancy, do serial Dopplers 1 to 2 weeks and begin antenatal testing at 32 weeks and deliver by 37, 38 weeks. Whereas if the velocity is more than 1.5, peak MCA velocity, then you have to go for a chordocentesis. This is the cutoff. Suppose you are a basic obstetrician who is depending on your MCA Dopplers. This is the critical point, that is 1.5 MOM, where you have to counsel, have a tie-up or refer or whatever. Then to go for a fetal diagnostic and also therapy. Chordocentesis to determine the fetal hematocrit. If it is less than 30%, go for intrauterine transfusion. More than 30%, you have to go for a chordocentesis again, see the fall in hemoglobin and hematocrit in 1 to 2 weeks and deliver around by 37 to 38 weeks. So the recent advances, as I have told, if we have the circulating cell-free fetal DNA, if we can detect, we are able to detect, but we are not able to, use it in a broader perspective, which gives us the fetal genotyping. Then point of care tests for determining RH tests, like I want to determine the homozygosity or heterozygosity of the father or the partner. If I have a POCT, then that would be very useful. And then 50 micrograms dose for following first trimester abortions, it is not widely available. Then again, we have a weak D antigen, whether she should be diagnosed as RH positive or negative. It is better to be, for the sensitization sake, to be label her as RH negative and give her the anti-D rather than RH positive. Whereas when you give a blood transfusion, it's another matter. So again, so ICT should be done at 20, 24, 28 weeks with appropriate prophylaxis at 28 weeks ideally, and again 72 hours, within 72 hours after delivery. And a single postpartum dose that we are giving for all women may be inadequate in case of severe FMH. That is one thing which we have to remember. But the problems is the high cost. But all the public sector hospitals have the anti-D now, and it is no longer such a big problem now. We see very, very, very rarely the sensitization and the affected fetus. Missed cases, poor documentation of prior sensitizing events, and loss of case notes, and all these things are this thing. So to conclude, it's a real problem and real efforts are needed. But incidence definitely, as I have told, has decreased dramatically. It is only around 1 to 1.2%. The total alloimmunization, not just D. Great advancements have been made, especially with ultrasound and Dopplers, which have really helped our RH negative women to have a happy obstetric career. Thank you, OGSH. Thank you, Vindhya ma'am, Archana, and Shanta ma'am, for giving me this opportunity to be part of this webinar in our, very hectic, and we have enjoyed.
Yes. Thank you, Kiran. I've got some now. There's a very nice message. Congratulations to all the great ladies responsible for the wonderful job. God bless you all, Dr. Kameshri. Dr. Kameshri madam has wished all of us, all of you at the public sector hospital, for doing the great job in this pandemic situation. We have some questions, but Jaideep has left, so I think I can handle them. One of the questions is, can we undertake MTP on a lady of 18 years, even though she's not married and with her consent only? We have heard Dr. Jaideep very clearly tell, anything above 18 years is okay. It gets covered under MTP Act. Any patient less than 18 years comes under the POSCO Act. So you have to report to the police, and then only you will have to go ahead and offer MTP. So beyond 18 years, married, unmarried doesn't make any difference. Okay, so MTP rule luckily doesn't have any provision of married or unmarried. So don't bring that question of married and unmarried in MTP law. Yes. And we have got one more question from Dr. Pushpa Gar, whether chemists are allowed to give MTP medicines. No, chemists are not. It is not an OTC drug. Chemists are not supposed to give the medical management of MTP drugs over the counter. It's absolutely no. Then there is one more question from Dr. Sweta. A 19-year-old unmarried woman comes at 32 weeks gestation. Now what to do?
Deliver.
You do 32 weeks, there's nothing else to do. I think you'll have to just deliver. There's nothing else left.
No, ma'am, can I actually, if I know Shweta, she's one of my juniors, I think she had put this query to me, but should she inform the police? That was one of...
She's 19-year-old. She's not under 18 years.
But unmarried. So married has no...
There is no question of married and unmarried. Why are you bringing that word?
Yes.
There is You should not be talking about that, Kiran.
No.
Marriage has nothing to do with the MTP law.
Suppose an MLC is made later.
MLC is irrespective of MTP law, doesn't talk about marriage. Marriage has nothing to do with an MTP.
The girl's family goes and puts a case.
Whatever, that you take legal opinion, but according to the MTP law, no.
It doesn't, no.
Other things will have to be actually dealt by your legal opinion. But other than that, I don't think we need to.
Madam, regarding MTPs,
yes.
Chemist, already we had an experience that incomplete abortions coming into shock, almost 346 cases. Those who required a major blood transfusion. Better we should not encourage that.
Yes, we are not allowed, and even legally also they are not supposed to give.
Second, regarding Kiran raised a point regarding MTP and informing police. I think it's a must, madam. Even if they don't want us to reveal, to medically protecting from ourselves, it is better to inform, but it should be a confidential one.
No, Dr. Rajalakshmi, according to the MTP law, it doesn't. The MTP law doesn't, it is confidentially, and you're not supposed to inform the police. I'm very clear about that. POSCO Act is different, less than 18 years.
But I had a case recently, one 18-year minor girl has delivered.
Minor, yes.
Baby delivered here, and they wanted now the legal proceedings for which medical record has to be submitted. In such case, what should be the doctor part in that? That should be clarified then.
According to the POSCO, less than 18 years, you should have informed before doing only. You have to inform to the police. Less than 18 years. So there is no question of not informing, whatever it is there, because it under the POSCO Act, it is even consensual sex is also not legal according to the POSCO Act.
But in the court of law, this is not accepted, madam. Only MTP law is accepted.
No. Now POSCO Act has come into vogue, and they are both are a little to be weighed and then discussed, and has to be done very, very carefully managed, because both of them have different aspects. See, one law is this thing, at the same time, under MTP law, you're supposed to provide MTP. But according to the POSCO Act, less than 18 years, you're not supposed to unless you inform the police.
Okay.
So thank you.
I wanted to know if they want, they can give a prescription for medical abortion. And they go and buy.
It's not an over the product. It's not an OTP.
Not an OTP, but give a prescription and they go and buy. Is it allowed for the practitioner?
It should be under supervision, madam. If you prescribe and
only under supervision.
Yeah, under supervision. If you give they use ridiculously, they land in problems. Ultimately, that practitioner who is given prescription will be penalized unless until if they go into complications. So most of the cases now we are getting to government hospitals by only prescriptions and not following. And even patient herself will not go. Once prescription is given, she will not go to the doctor again, because patients are also nowadays smart and they are Googling it, and the precautions, complications, everything they will be known. And they are landing in shock to the government sector. So the cause for the shock is not known once we receive the patient. Unless until they will not show any prescription also. Again, we have to dig for the cause, why she has gone into shock. Day before yesterday, we had one case. Patient came in shock, no attender, even husband also ran away. But thing is, when I examined, it was our DMO has informed me she was in shock, short breathlessness and everything. But we thought maybe ectopic. Then we examined, no. And she had multiple tears and she is pregnant also. And part of conception products are there. So we have repaired it under GA, and she was struggling for almost 8 to 10 days with us, went into failure. Luckily, we saved her. Then that case was informed to the police, because we don't know the cause for her shock status.
Yeah.
So those are the things with the prescriptions regarding MTPs. If we are sure that patient is coming back to us, then only prescription is holds good, in my opinion, with the public sector. Otherwise, it will be a problem because patient will not stick to one doctor. Once she starts bleeding, she thinks she has aborted completely, or else she think everything is over. So definitely, it needs supervision, madam. This is my experience from these 4 months.
I think the same thing even in the private sector.
Yeah, it should be.
We should not give any prescription. And
you should not.
Yeah.
You should.
One useful thing is I still remember that case. Everybody dubbed a 15-year-old as pubertal menorrhagia in GMH, and they were so innocent. And one of our senior DMOs only somehow didn't do a urine pregnancy test. And I also believe that history they were treating her as pubertal menorrhagia and anemia. So the next day, one of our professors, Dr. Uma Madam, she took 1 hour history. Finally, they revealed, the girl's friend had given over-the-counter medical abortion, and when we did the scan was normal. She was severely anemic with fever, septic abortion kind of thing. Then UPT was positive, and one more important thing was after 1 month there was a Rasta Roko on highway. 2 villages had blocked because of this case. They didn't make an MLC then, but because we did UPT, madam asked me to mark it as an MLC and write it down in a register. Then the police, I think one of the high officials only had come to the hospital. He made me write then and there the opinion. If we had not done UPT, then we would have totally missed the case. So any young girls with such things we have to, because history will not be.
Prescription also holds good, but thing is, patient should be in a follow-up state. That means you should have confidence that patient will come back in private sector. Then only it's good. Otherwise, we may miss the case and she may land in some complication. The first thing is, the first who has given the prescription will be the culprit or penalized. I think
there is one more. Yeah, there's one more question. Is a doctor punishable if they refuse MTP for any patient, if asked for, even when she has a genuine reason for MTP? Yes, can a doctor refuse an MTP? Every doctor has a right to refuse any treatment at any given point.
Unless it's an emergency.
Unless it's a life-threatening emergency, then you are penalized.
Shock with incomplete abortion and all.
If she had incomplete abortion and in shock, you are penalized. Yeah. But if she comes for a routine elective MTP, you can send her to a colleague. Yeah. Then there's one more question. Police doesn't come in time to collect the products for DNA. I think let's leave it, because now in this pandemic, police and we have become little close. Let us make good friends.
No, they are good friends of us. Yes. We should not blame them.
We should not. There's one more. MTP is being done for a minor following MLC norms. Are we supposed to? Of course, now that comes into the POSCO Act. So there you have to inform the police and follow all the norms.
That is only
Kiranmai, there is one question.
It doesn't become less, you have to do a urine test.
Please listen, Kiranmai. Do we have to give anti-D to an RH negative patient under Encirclage at 20 weeks with the negative ICT? Dr. Uma Devi.
Encirclage is not among the listed indications. There are ACOG indications with ABC and all. So Encirclage is not listed. Whereas external cephalic version, then other amniocentesis, threatened abortion, ectopic are all listed.
So you don't. Then other question is, if a twin pregnancy, do we need to give higher dose of anti-D? Now this is
it is only about the hemorrhage. Actually, you have to assess if you can, the volume of the hemorrhage and then give a bigger dose.
But we really never managed to do it clinically.
Yes. Generally, we give a 300 microdose.
It's only for talking, we will talk like that. But have we ever analyzed? I have never done in my practice. I'm sure none of you all have also done. Oh. Okay, that's it. So I think this was a wonderful discussion with a lot of interaction. Thank you very much to all the participants and of course the viewers for logging in with us. We had more than 1,000 viewers, and special thanks to our Science Integra, Session, Subbu, Sana and the whole team, and of course the Bharat Serum for being the educational partners in this OGHS webinar. So thank you very much.